دكتورة مرام الخطيب. دكتورة مرام الخطيب is a consultant general surgeon and an assistant professor at King Abdulaziz University. She's also a diabetic foot specialist. Dr. Maram, I'm proud to say that she's part of Dr. Idrис Specialized Medical Center. She's an attending physician with us, and it's an honor to introduce you, يا دكتورة. ما سمعتني.
السلام عليكم ورحمة الله وبركاته. It's a great honor to be here among all these pioneers in diabetic foot in all aspects. Thank you, organizing committee, for inviting me. Let's start. My topic today is going to be regarding updates on clinical approach of diabetic foot ulcers. Our main problem, our main enemy is like the underestimation. And this is the message that I like to give always in my lectures. What we think, if any patient, if any physician gonna see this patient in the clinic, he gonna say, oh, it's a little ulcer. It's a small wound in a little toe. And this is a big issue and a big problem. Putting in mind, having an ulcer, it means that the patient is having neuropathy, vasculopathy, immunopathy, and injury. If we are considering each patient coming with an ulcer with this problem, we have to take it seriously. Again, as the one that Dr. Yusuf already was discussing regarding pathway of foot ulceration, when we know that the patient is having foot at risk, one of the big problems we have that not all the people are thinking of diabetes as a syndromatic problem. Talking about diabetes means distal neuropathy, muscle wasting, loss of protective sensation, having the autonomic or sensory neuropathy plus the peripheral arterial disease, putting in mind the metabolic and the immunity problems. These all gonna impact and putting this patient at risk of foot at risk and then at having an ulcer at last. Neuropathy is the most common cause in like around 80% of the patient. 60% of the patient gonna have the triad of neuropathy, deformity, and trauma. Ischemia always at almost a third of the patients. When we know that more than 80% of ulcers are potentially preventable, it puts a very high burden on the screening and preventive measurements. What's the most common types of foot ulcers in diabetes in general? Neuropathy, ischemia, or neuroischemic as a combined. When we are talking about neuropathy itself, we had a part of the peripheral neuropathy and nothing regarding the peripheral arterial disease. Commonly coming on the plantar surfaces of the foot and toes. Usually it associated with neglected callus, high pressure plantar area. And most of our patients, when they have this neuropathy, it's the best to be managed from the start by the screening. When we see any deformities in the foot, having any hyperkeratosis or callus, we put in mind that this patient gonna end up by an ulcer, which may end it by amputation. Regarding the ischemia, the peripheral arterial disease, and whenever we get an ischemic foot or ischemic ulcers, put in mind that it has the worst outcome than neuropathy. And most of our population gonna have the neuroischemic, unfortunately, if we're having both neuropathy plus ischemia. And this is what we see most of the time at the tip of toes, at the back of the heel with the pressure areas, trauma, or wearing unsuitable shoes. From this table, we can see different type of ulcers and the presentation and the optimum way of management. Starting with the venous. Most of the time, if you think about venous ulcers, always the conditions that with the history, you can have varicosity, previous DVT, obesity, pregnancy, recurrent phlebitis, and it will be on the calf muscle, on the medial area around the medial malleoli. And this is the way of the saphenous vein location. Regarding the ulcer characteristic, it will be shallow, flat margins, moderate to heavy exudate, slough at the base with minimal granulation tissues. The specific or pathognomic, you're gonna see the hemosiderin staining, thickening and fibrosis, itchy skin, the lymphedema, and normal capillary refill. The mainstay, the cornerstone of treatment is compression therapy, leg elevation, surgical management if required, and for sure the wound management. Regarding the arterial, when we put in our mind that the background of all the comorbidities like diabetes, hypertension, smoking, previous vascular disease, then the pressure points always the place or the toes at the free the lateral malleoli. Regarding the characteristic, the time Dr. Yusuf just mentioned, it will be pushed out, deep, irregular shape, and healed on bed, necrotic if it's affected, and the leg and the foot will be shiny skin, reduced hair growth, cool skin, delayed capillary refill, may present with gangrene and absent distal pulses. Regarding the management, here you have to go first to the vascular surgeon for revascularization and to consider the medical optimization with the antiplatelet therapies. Neuropathic diabetic foot, and this is the most that we see in our daily activity in the clinics with diabetes, trauma, prolonged pressure. Put in mind that most commonly at the plantar aspect of the foot, the tip of the toes, any place can be hit by trauma or unperceived trauma with loss of sensation. It will be deep, surrounded by callus or hyperkeratosis, as that's like obvious in the screen, and the patient will gonna have a dry cracked loss of sensation with callus. And the main part of treatment is the offloading of the pressure and continue on wound care with the medical optimization. Whenever we have a pressure ulcer, actually the background will be like limited movement or bed-bound patients, bedridden, and it will be on the bony prominence, especially the heel if you are talking about the feet, and most of the time it will be deep, macerated, atrophied skin, and the treatment will be offloading of the pressure with all the aspect of protecting the skin from shear forces, friction, and so on. Classification, I'm not gonna go through that because Dr. Yusuf already discussed most of that. But what I just want to clear or to clarify is that we have a lot of classification. Wagner, it depends on the anatomical only. The Texas depends between anatomical and clinical, and the IDSA, it's only mainly on the clinical situation. Sinbad, the one that is being used with the International Working Group of Diabetic Foot. And this is like a quick screening part when you put like a scoring that you know that their patient is gonna have a prolonged time healing. It's a quick one and easy by site, ischemia, neuropathy, the infection burden, area, depth. When we know that third of our people with diabetes gonna suffer from diabetic foot ulcer in their lifetime, and third of them, the one with ulcers gonna end it up by amputation, again, we're gonna keep repeating screening and preventive measurement and programs. But the good thing that, you know that even up to 85% of patients with amputation can be prevented if we're gonna follow the holistic multidisciplinary approach. Because roughly around 60% of diabetic foot ulcers gonna come with infection at the presentation. Dr. Yusuf was mentioning regarding the risk patient. We have to put the patient at risk, always in close follow-up. So this is like an info card, which we're gonna make it easy for you. You can categorize your patient in low risk or moderate risk or high risk or very low risk from the start. Starting with a simple test, as Dr. Yusuf already mentioned, regarding the loss of protective sensation and the arterial examination. If the patient doesn't have any protective sensation or peripheral arterial disease, you're gonna see him on annual basis, like on yearly basis, and you're gonna follow your patient. Regarding the others, whenever you have loss of protective sensation or arterial disease, here you're gonna see your patient on 6 months. Keep in mind, you identify risk factors of disease, food deformities, any pre-ulcerative signs, any hyperkeratosis, putting in mind education, food care, and regarding the therapeutic footwear and orthotics. After that, if the patient already started to have the protective sensation lost and peripheral vascular disease or having any deformity, already you know this patient is like on moderate risk of having ulcers, and he has to be closer follow-up within 3 months. Again, we're gonna follow all these things, putting in mind that whenever the patient started to have any hotness, any swelling, to come directly to your office and not to wait follow up in a future time. The high risk, whenever already the patient is having already ulcer, having minor or major amputation with the protective sensation for sure, and any renal diseases. Okay, now if we get an infection, let's start to talk about the management plan. So I'm covering one of the clinics and my patient came. We'll put them on this classification to make it easy. Which of them? Gonna give him antibiotics and discharge, which gonna we admit him or start him on parenteral antibiotics. Go with this classification. It's so easy, and you can just have it in your mobile, in your clinic, whatever. Starting with, if it's only mild infection, local swelling, erythema more than 0.5, local tenderness, and purulent discharge, can be discharged on oral antibiotics. What about if it's a moderate infection? You mean that it's only local infection again, but now the erythema started to be more than 2 centimeters, or it's going deep, or you are putting in mind that it may reach more than the skin and subcutaneous tissues, but no systemic inflammatory response. You can start him with higher or like broad spectrum oral antibiotics, or started with initial parenteral. And the severe, as you can see, there will be starting with systemic inflammatory response by the known by temperature, high tachycardia, tachypnea, and leukocytosis, which is going to put in mind that there is a risk of osteomyelitis. It was faster than the computer. Regarding the osteomyelitis, when we think that there is a risk of having diabetic foot with osteomyelitis, whenever you have a patient with prolonged or recurrent ulcer at the same time, put in mind this may have underlying osteomyelitis. Deep ulcers, difficult to heal despite the optimal treatment for more than 6 weeks to 2 months. And keep in mind that X-ray, it's not a good diagnostic from the early phase. Always MRI is a gold standard, and the X-ray gonna show you when it's chronic osteo, not acute. So what's the step to diagnose diabetic foot osteomyelitis? First, we know that the clinical sense, one of the things, whenever you have the same previous slide that I were talking about, recurrent ulcers, deep ulcers, and if you have a probe bone test, that if you have any metal forceps or any probe that you can touch the bone, you put in mind that touch bone, the find showing osteomyelitis, this is more than 90% osteomyelitis. SR, CRP, all inflammatory markers can give you a hint that an osteomyelitis underneath the X-ray finding. So whenever you see your findings compatible with osteomyelitis, you have to start the management of osteomyelitis either by medical or surgical. Surgical if it's already there, or you take bone samples and you go with antibiotics for 6 weeks. If it doesn't seem that there's an osteomyelitis, so you treat infection as antibiotics, and you put in mind you have to go for a higher specialized more diagnostic imaging like MRI, or if you have CT scan with contrast or leukocyte scintigraphy, like if you have it in your hospital. Always remember that we need a team-based approach. We need the medical, vascular, the family physician, the wound care nurses, the pain specialists, orthopedic, podiatrists, and all of them, we have to work together to ensure that the patient is gonna be in a good hands. Therapeutic approach, as I mentioned before, we start whenever the patient coming into the clinic or to the emergency, it depends. We're gonna start with broad spectrum antibiotics after we took a deep tissue culture. Don't take a swab anymore. Don't take any tissue culture from your face. It will be all colonized, and this is not the main bacterial organism. So always you wash only by normal saline, not any bacterial solution or antibacterial solution, and then you can just take the deep cultures. Then surgical treatment if needed after good vascular assessment. Don't forget to assess all the medical condition and optimize it, from blood sugar control, all the comorbidities, the malnutrition, and the renal function. To make it easy for you, Matador can be used. Matador always, it's easy. It's from one of the Italian physicians. He invented this to easy to format, metabolic, and the medication. You can see with the assessment, you have to examine your foot, making sure that your perfusion is fine, the size, depth, and infection, and the sensation. Debridement, if there is any necrotic tissues to be cleared up, and antibiotics. We start always with the broad spectrum, and until we get our sensitivity and culture, then we can just narrow our spectrum on antibiotics to be targeted. Then the dressing with the frequent wound care and dressing, offloading. This is the mainstay of treatment for most of the wounds. Referral, facilitate always any quick referral for a patient that is in need for the specialized or highly specialized centers. Education, always we keep telling about education, which means to our students, to our doctors, to our residents and our colleagues, and then the patient and patient's family. Thank you so much.
Thank you, Dr.